Okay, we're recording. All right, second time's a charm. So I'm Laura with Boston Scientific. Thank you so much for joining us. I know it's been a long time since we've been able to meet in person, and I know that there are some participants on Zoom, so we wanted to thank you for coming through and listening to the presentation. I wanted to introduce Dr. Davis, who has a CV that's really long, and I feel like I've gone through half of it already. But with that, he did his fellowship at the University of Alabama, Birmingham, where he focused in stereotactic and functional neurosurgery. He's been an amazing asset to Tallahassee Memorial, and I've personally seen him take extra special care of his patients, and we've seen some really amazing results through there. We are really, truly blessed to have him. So with that, Dr. Davis.
All right, perfect. Pleasure to meet you all. We have confirmation that the Zoom folks are able to hear us.
Yes.
Yes.
Sure thing. Is this better? Okay, perfect. So yes, thank you for the introduction. I'm Dr. Davis. Okay, so I'm the functional neurosurgeon here at Tallahassee Memorial Hospital. That means that my subspecialty training is in the surgical treatment of movement disorders, including essential tremor. So we're going to be talking about essential tremor, the surgical options, the non-surgical options, and a little bit just more in detail about what can be done for patients with essential tremor. Go ahead and go through here. All right, first of all, let's talk about what essential tremor is. All right, essential tremor is not Parkinson's disease. All right, it is a benign condition in the sense that it is not associated with all the other things that Parkinson's disease and other movement disorders are. So it is essentially simply a tremor, usually of the upper extremity, sometimes of the head and neck, occasionally of the legs. All right, but it's not progressive. There's not the cognitive changes. There's not the non-motor symptoms that you get with some of the other things, or other movement disorders like Parkinson's disease. It is incredibly common. All right, up to 10 million Americans are thought to have Parkinson's disease or have essential tremor. That's 10 times more than Parkinson's disease. So it is far more common than Parkinson's. The average age of onset, the slide here says 40 to 50 years of age. That's usually when essential tremor is diagnosed. All right, most people on further reflection, thinking back, will say, no, actually, I've had some tremor for many, many years, often decades. And then it doesn't usually progress to the point of needing treatment or getting diagnosed until in the 40s or 50s. But I've seen patients in their 20s with essential tremor. I've seen patients in their 80s with essential tremor. As I mentioned, essential tremor can affect any part of the body, but most commonly it starts in the hand. It will quite frequently, one side will be affected first, and then it will move to the other side. There can be non-motor symptoms with Parkinson's disease, but that usually requires a lot more workup to make sure that you're not dealing with Parkinson's or one of the other movement disorders. The tremor is different in essential tremor. All right, it is not a resting tremor. So if you're just sitting watching television, typically there's not significant tremor. But when actually actively moving, all right, is typically when essential tremor is the worst. That's different from Parkinson's disease, in which there is a baseline resting constant tremor that people can't control. It's a little faster than Parkinson's disease, in more of a like this motion instead of the slower that you get with Parkinson's disease. There's often a strong family history of essential tremor. Not always. At least half of the time it's spontaneous. It's the first time in your family, but quite frequently there's a history of essential tremor. Patients will say, my grandfather had it and my father had it and so forth. The bit here on alcohol, often people will say with essential tremor, if they have one drink, that there's a reduction in the tremor. Again, not always. And the targets are different. in terms of when we get to the surgical side of things, where the electrode is actually placed in the brain. It's placed in a different place for essential tremor than it is for Parkinson's disease or dystonia. So let's go over some of the treatment options for essential tremor. The first step in treatment is with medications. And there are two that are used most commonly. One is propranolol, which is a beta blocker. A lot of people are on those type of medications for heart conditions already. And the other is a medication called primidone. And both of these can be helpful, and especially in the early stages of essential tremor, that is the first line treatment for essential tremor, is in medications. We have a question. Okay. Better? Okay. So first line treatment medications. Botox is an option for certain people with certain types of tremor. And these are people who have a lot of tremor in their head and neck and a lot of tremor in their voice. Most people with essential tremor don't really fall into this category, but there are some. There is also options for therapies, all right? And the therapies are not designed to take away the essential tremor. They are designed more for living with it and learning adaptive strategies and techniques. Different, for example, spoons and forks can often be really hard for people with essential tremor. Well, oftentimes people will come in and say they haven't had soup or peas for a decade because they can't keep it on the spoon. There are therapies that can help people to live with essential tremor and adapt their activities in order to deal with the symptoms. Another option, and this has become more of historical interest really, is ablative procedures, all right? So deep brain stimulation, which we'll talk about in a lot more detail, is when a thin flexible wire is placed into a certain portion of the brain that controls the tremor, and that's connected to a battery that's like a pacemaker battery, all right? And that controls the tremor. Traditionally, this we're talking 30, 40 years ago, there were a variety of techniques to actually destroy that area of the brain, all right, and intentionally destroy it. And whether that is with high dose radiation or with a probe or with ultrasound, with focused ultrasound, all of these technologies, these other procedural options are destructive ablative technologies. And as a general rule, they don't work as well as DBS, and the effects don't tend to be as long lasting as DBS. And so they, in this day and age, have really become options for people who cannot undergo surgery for whatever reason. And then finally, deep brain stimulation has become standard of care for people with essential tremor whose symptoms are not adequately controlled on appropriate medications. It is not experimental, all right? It is not new. DBS was FDA approved in '97. Hundreds of thousands of DBS electrodes have been placed all over the world over the past 25 years. And it is, of course, covered by all major insurances. It is the standard of care if you still have life-dominating or life-altering symptoms despite an appropriate medical regimen. So we're not talking about anything experimental or out of the box. So let's talk about deep brain stimulation in more detail. So DBS is a surgical procedure. It is done in the operating room, all right, and done with real-time computer-navigated guidance to place a wire through the skull into the part of the brain called the thalamus, and a specific part of the thalamus that's actually responsible for controlling the tremor. The procedure takes about an hour and a half. All right, people are actually awake during a portion of the procedure to participate in testing. And so we place the electrode and then with an external battery, turn it on. Make sure that you're going to have great tremor control and you're not going to have any side effects from the stimulation. All right. Nothing is ever perfect, but I expect as close to 100% on every single case and for every single patient. And as we'll talk about, success rates are around 98, 99%. Okay, so this is not a Hail Mary pass either. So the wire is placed into that portion of the brain, and then in a separate procedure, patients go all the way out to sleep, and the wire is tunneled under the skin, behind the ear, down to the chest, and exactly like a pacemaker, a small cut is made and the battery is placed in the pocket. Okay, that's an outpatient procedure.
We actually have a question from the Zoom audience.
Yes.
They're asking, what is the Nucleus
The ventral intermediate nucleus of the thalamus is the target that is used for deep brain stimulation. So it is a small area of the brain. The whole thalamus is about maybe the size of a large grape, all right? And the VIM nucleus is even smaller than that, so it's a very small target. And that is the area of the brain that is affected in essential tremor, and that's the location that is targeted in the surgery. Feel free to interrupt me at any time with questions, and we'll also have a question session at the end. Sir.
Is this condition nerve-based or muscle-based?
This is based in the brain. That's correct. And the question was, is this condition nerve-based or muscle-based? And no, this is not something that originates in the muscles. It is actually a condition that originates in the brain. Okay. And I think, do we have the actual DBS electrode systems? Yes. So whether we do it passing around or be able to do that at the end as well. So for the people on Zoom, actually, I'm going to take the lead. Okay. Be able to demonstrate. So we have this very, very thin, small, people on Zoom, I can't see you, but very thin, flexible lead, all right? And the tip, this area here, this is where the actual stimulation comes out. And then let me see the battery, Lisa. Again, we'll take this all around. And the battery here, very thin battery in terms of width. This is the overall size for the people on Zoom, okay? And again, we'll pass this around as well, just so you have an idea of exactly what we're really talking about.
And how long is that battery good for?
So it's an excellent question. The answer used to be, well, the answer is still, it depends, okay? So for people who have electrodes placed on both sides that are requiring a lot of current, a lot of stimulation, it used to be that those batteries would only last 2-3 years, okay? Somebody who turns the system off at night and only has one side may have gotten 5 years out of the older battery systems. They now make, and we'll talk about this, rechargeable battery systems, okay? And we'll even have a little video on this. And those batteries, 15 years is what's thought they'll last. When the battery needs to be replaced, that's a 8-minute outpatient procedure where you go to sleep, the battery is taken out and a new battery is put in, and then you go home. Okay, so as we already went over, it's not experimental, it's not a treatment of last resort. There have been many hundreds of thousands of DBS electrodes that have been placed. 98% of people would even recommend it to others. And what does DBS help? Well, it helps the tremor, and that's it. All right, it's not going to give you a facelift. It's not going to make the sun come out tomorrow. It helps reduce the tremor. All right, but when the tremor is preventing you from doing all of the things you want to do, that's huge. That's great, and it's a massive improvement in quality of life for patients. So we'll talk about the steps. Again, we've already discussed the initial steps with medications, and then obviously a surgical evaluation. So that's when we meet and talk in person about DBS and exactly the steps of the procedure. There's then the lead that gets implanted, and that's the wire that goes into the brain. And then the battery gets connected. And then there's a programming process. This is not just a set and forget machine. You actually, in clinic, we actually adjust the settings, how much current, which direction the current is pointing, to get the best tremor control with the least use of the battery life. And that process usually takes a few visits. Essential tremor is quite a bit easier in terms of the programming than something like Parkinson's disease, but it still usually takes a few visits to really get absolutely perfect control where you're able to do all the things you want to do. So we already mentioned not experimental twice. Oh, this is important. There is a very common question I get is, will it stop working with time? And 20 years ago, we really didn't know, but we do now. DBS continues to be effective for decades, all right, for the duration of your life. There may be programming changes that may need to be made over the course of years, but it does not become less effective with time. those ablative, destructive technologies and techniques that I mentioned, those do lose effectiveness. Not in every patient, but the quality of life does decline over time with some of those ablative technologies. I mention that specifically because there's been a lot of excitement and interest in something called focused ultrasound recently, and that only recently got FDA and then CMS approval to be covered by insurance for essential tremor. And it's not to say that it doesn't work. It does. It just doesn't work as well as DBS, and it has that same risk of losing effectiveness over time. And it's a destructive technology that destroys the portion of the brain, and you hope that you don't miss, which is not the case with DBS.
So is DBS covered by Medicare?
Yes, DBS is covered by all major insurance plans and has been for 25 years. Sir.
What symptoms should we be looking for?
So the symptoms, especially with essential, you mean with essential tremor?
Yes.
So the question is, what symptoms are we looking for with essential tremor? And so traditionally, the most common essential tremor patient is someone who develops a tremor, usually in the arm or hand. And that tremor is worst when reaching for objects, when doing delicate tasks, when using the arm. All right. It's not present when you're just laying there watching television. Okay. A presence of a rest type tremor does raise concern for other types of movement disorders. That's not so much true for the head and neck tremor, people who have that, where there's a lot of shaking like this. That's present even when just sitting still because you're still activating all of those muscles just to keep your head up.
I do have a question from the audience, and it's somewhat related. How to differentiate between essential tremor and early Parkinson's if just one finger is shaking or something like that?
It can be very challenging, and there are times that we don't know until the passage of time. Yes, the question was how to differentiate between essential tremor and early Parkinson's. And the answer is that it can be difficult. All right. There are times when we don't know until we see how symptoms change over the course of years. From the surgical perspective, if someone just has one hand twitching and hasn't tried any medications, we're not anywhere near talking about the surgical side of things yet. You're still in medications. There are things that can give you hints. For example, the family history, if there's a family history of essential tremor, the age of onset, if there are any other symptoms, though for this person, it sounds like there aren't. And then the most telling way is with different medications. So there are different medicines that are used for Parkinson's disease than are used for essential tremor. And so if there's a lack of response to essential tremor medications, but there is a response to Parkinson's medications, we'll have a lot of your answer right there. And the final thing on this slide, DBS is a highly invasive permanent procedure. Well, it is a surgery. It is done in the operating room. There is a cut involved on the head and there is a cut involved on the chest. How invasive you want to think of that, it's going to vary from person to person. But it is not irreversible because, as I've said, unlike those destructive technologies, DBS can be turned off, can be removed. We hope we never have to do that, but it is not destructive in the same way. Yes. Excellent question. So the question was, is essential tremor hereditary? And is there anything that can be done to prevent the onset of essential tremor? DBS, essential tremor is often hereditary, but not always. All right. There is maybe anywhere 40–50% of the time some family history of essential tremor. And there's not really anything that has been clearly shown to delay the onset or to any way affect the course of the disease. Essential tremor will continue your entire life, and it often will slowly get worse over the years. That doesn't change even with DBS. So if you get DBS and you turn it off, your tremor is going to come back, but it will continue to remain effective as long as it's turned on for the rest of your life.
Dr. Davis, I have one more question from the Zoom audience. Does DBS work effectively for vocal tremor?
DBS does work for vocal tremor for the central, I'm sorry, the question was, does DBS work for vocal tremor? The answer is yes. It will require electrodes on both sides of the brain in order to get good central and axial tremor controls. And that's part of the counseling and discussion process. But yes, it absolutely is effective. And it can be wonderful for that, actually. We have another question.
So are there negative side effects to this? And is it possible interference with other brain action or anything?
So the question was, what are the possible side effects with DBS and can it interfere with other brain activity? And the answer to that is that while there can be side effects, the risk of that is extremely low, especially because the DBS system can be turned off. But the whole point of patients being awake for any of the testing during the surgery is to ensure we're not going to have problems with side effects and that we're going to get the best tremor control. I hope that answers the question. The other thing that you asked was whether it interferes with other brain activity. The path that the wire, that this thin flexible wire passes through is specifically chosen to not interfere or disrupt with other brain circuitry. Is there another question? Yes.
I have a brother who was diagnosed a few years ago with Parkinson's, and he really, his right hand really shakes an awful lot. But would you be able to tell as a professional, if you didn't know it, whether he had Parkinson's disease or whether it was a tremor?
So as I sort of alluded to with that, I'm sorry, the question was, how do you really tell between essential tremor and Parkinson's disease? And like with that patient who had one finger tremoring, there are signs you look for. In general, if you get to the point of having a diagnosis, of being on medications, of having a very active tremor, it's relatively easy to tell the difference. There are also other things you look for in Parkinson's disease, other motor symptoms, other problems with movement, slowed movements, rigidity, things that don't happen in essential tremor. And then, of course, there's a response to medications. Thought I saw another question. Yes.
Are there any instances, when would this particular treatment?
So there are relatively few, the question was, what are contraindications to surgery? There are relatively few absolute contraindications to DBS. So being so medically ill that you could not undergo even a 15-minute procedure where you had to have a breathing tube would be one contraindication. Not being able to be off of, if someone is on blood thinners, not being able to be off of blood thinners for more than a few days, which is the amount of time that would need to be held. Relatively few people can't be off of blood thinners for 5 days. There are cases where it's really not safe, people with really terrible cardiac problems. There's not, another very common question I get is there an age cutoff? Is there an age limitation? And again, the answer is not really. I have placed a DBS electrode for essential tremor in an 89-year-old man. Now that 89-year-old man was still working and had no other health problems. So there will be relatively fewer people getting up towards 90 that would not be a potential candidate for DBS, especially for essential tremor. Oh, yes, sir.
Doctor, first, thank you for being here. I've had these since my 20s.
Uh-huh.
My mom had them. They're starting to affect my golf game. So I understand I'll have to start with the medication and then maybe get to the DBS. I see there's 2 medications that are primarily used. You mentioned, which of them should I recommend to my doctor to take a look at?
Well, so the question was which medications are best to start with for most folks. And that depends on your medical history. People who, I would say that in general, the side effect profile of each of the medicines is different. Primidone, most common side effects tends to make people sleepy. All right, propranolol has its own different side effects. I would say that it really does depend. Both are good treatment options, give relatively similar tremor control. Most people who don't have a significant cardiac history tend to start on propranolol first. And that's usually, what I see most commonly. And another question.
Does it limit the use of an MRI?
The question was, does DBS limit the use of an MRI? The answer is no. There is all of the systems now are MRI compatible. You will, and we'll talk about this in a bit, but patients get a home programmer, and before an MRI, the DBS system is turned off for the duration of the MRI scan. But no, there's no limitation on getting an MRI.
Dr. Davis, I've got two from the web.
All right.
Can you tell the difference between cerebral tumor that causes tremor and essential tremor?
Yes, you can. And the question for those in the back was, can you tell the difference between whether it's a tumor causing a tremor or essential tremor? And the answer is yes, you can. The easiest way is with an MRI scan, of course, but also the presentation of these things is very different. So essential tremor typically has a history going back decades, gradually worsening over time. Brain tumors simply don't do that. And it's also, frankly, very rare for a tumor to initially present with a tremor. That's almost unheard of.
One more.
Okay.
So does the medication for essential tremor agree with other medications for things such as peripheral neuropathy?
It depends. I'm not sure I can really answer that question in the general sense. Typically, for the vast majority of patients, the doctor will take into account which other medications you're on before deciding between the medications and discussing dosages with you. Okay, so when to consider DBS? And this is a really important slide because DBS, especially for essential tremor, this is a quality of life procedure, okay? So if you have a minor tremor and it doesn't bother you and it doesn't affect your quality of life, you don't need DBS. You may not even need medications. The time to consider DBS is when the medicines aren't working well enough for you, or you can't tolerate the side effects from the medications. All right, there's no benefit to getting DBS done early because you think it might get worse. All right, DBS is about quality of life. It's about improving function. And what that looks like can differ a lot from person to person. So for one example, I placed DBS for an engineer, a gentleman who was still working, but he couldn't do his fine drawing and his delicate tasks well enough to do his job and to be happy. You would not have known walking down the street that this man had life-altering essential tremor, but he did. For what was important to him, it was affecting his quality of life. We heard about affecting a golf game. All right, if you are a really avid golfer and you can't get out and do what you want to do, you got to do something about that. All right, but DBS, as we said, does not change the fact that essential tremor, it does not cure essential tremor. It fixes it for the rest of your life, but you only want to consider DBS when you are having life-altering symptoms. Okay, and it is okay if the medications, if the side effects from medications are themselves impairing your quality of life. If you can't get up and do anything because you're so sleepy from the primidone, or you're having issues from the propranolol, that is also a reasonable time. You still have life-altering essential tremor despite what medications you're able to take. So we're going to talk specifically about the Boston Precise system. We'll talk specifically about the directionality. And specifically about the batteries. There are non-rechargeable batteries, all right? So for folks who really don't really trust themselves to remember to do the charging system, which we'll talk about in detail, there are still non-rechargeable batteries. We just accept the fact that they will last 2 to 5 years instead of 10 to 15. As we said, and that's a choice that we discuss in the clinic. The benefits from the non-rechargeable are that you don't have to charge it. The downside is you're going to get it changed more often. The rechargeable system, it is smaller, so especially for really thin people, it's not as significant of a profile, and you don't have to come back and get the battery changed as often. So we're going to talk about the system specifically. We want to talk about the directional nature, which is really exciting. It's something that in all fairness, Boston really led the field in. They are MRI compatible. So one of the exciting advancements in DBS came with Boston with the development of the directional lead system. So what that means is that with this little thin flexible wire, the current can actually be pointed in a particular direction and away from other directions. And that really gives us a huge range to be able to get the absolute best tremor control with the absolute least side effects. All right. We briefly discussed the fact that the ventral intermediate nucleus of the thalamus is the target for essential tremor. It is small. We're talking about less than a pinky nail in terms of where you're aiming, and placing it the electrode into that target really provides just outstanding tremor control. Yes. Right. So the question was, when we're placing the leads in the OR, how do we know? Yeah, it's not a close your eyes and throw the dart. So you use a computer navigation system. So before surgery, patients have gotten an MRI and a CT scan. And then in the operating room, actually use a CT scanner in the operating room to get a CT scan of your head. And those pictures get merged together with the MRI that we got before surgery. And then again, using the computer navigation system, identify the target, identify where the electrode is going to go in, and then that then allows me to know where on your head the cut is going to be and where the electrode is going to be placed. I think we'll probably skip over the details of how a directional system works. The end result is that you're able to change how much current is coming out of each one of these little dots on the wires to attain the best tremor control. That's really the most important.
So is the issue with the thalamus that it's not working and it needs stimulation, or it's working too much?
So, boy, that is a very interesting question. The question was, what's going on with the thalamus? Is it working too much? Is it not working enough? Why does poking it with an electrical signal 170 times a minute do anything? And anyone who really thinks that they have the answer to that is lying. In the 1960s and 50s, based on some work done in dogs, we thought that we knew how the basal ganglia worked and how it controlled muscle movements and how it controlled tremor. And every year since then, there's been some new circuit that's been discovered, some new pathway. What we know is that it works. All right, even though basal ganglia circuitry is actually enormously complicated and not as well understood for essential tremor as it is for Parkinson's disease, even there's a fair bit of hand waving involved. We know that it works. We know that stimulating the VIM of the thalamus. Yes, it is one of the stops of the motor pathways of the basal ganglia, but what's important is that we know that it works. And we know that it's the best target, having tried all a huge range of basal ganglia targets over the years. Again, rechargeable batteries are great. So yeah, we have a great video here that I want to show you. The way that these rechargeable systems work is, if you've ever seen a charger where you take your phone and you just put it down on the thing and it charges it remote, same idea in terms of how the rechargeable system works. So you put on this neck pillow type thing, sit down and watch an episode of television. You do that once or twice a week and that recharges the system. Battery continues to be at very high capacity even after a decade, depending on how much stimulation somebody requires. They might be recharging once a week, they might be recharging once a month. Let's see if our video is going to work now. We're not getting video to the audience, however. Well, we can still. I want to at least leave this up for long enough to see the charging device that gets placed. Essentially, you turn it on, you put it around your neck, and you turn on the television and take it off 30, 40 minutes later. Yes, it is required. Yes, yeah. Very dangerous to not. Yeah. And so, in addition to the home charging system, patients also get a programmer. All right. And this actually allows you, within certain parameters that we decide on in clinic, to change the amount of stimulation that you're receiving. Okay. Also to be able to turn it on or off. All right, so if you're doing really fine motor work and you really need optimal tremor control, you can actually, within those parameters, increase the amount of stimulation and then back it back down when you're just doing normal activities. You can turn it off for an MRI, for example. It used to be when people, before we had rechargeable batteries, that people would turn the system off at night to save battery life. Now that we have rechargeable systems, that's less relevant for folks. I also tell folks that if you go out fishing and you really want that jig back, you can turn it off for that. So there are various reasons, but it really does give people a lot of control over their system and their stimulation. Okay, well, we've kind of had questions going through the whole process, but other questions? Sir?
How does this affect bathroom function?
So the question was, how does it affect bathroom functions? And the answer is, it doesn't. It's not going to make it any better. It's not going to make it any worse. The smooth muscle systems that are involved in bladder control are different than the major muscles that control your arms and legs and head. And so there should be no worsening, but it's not going to improve bladder function. Other questions?
So I'm interested, I need to start with the medication first, it sounds like, doctor, and that's through my primary care physician.
Typically through a primary care physician. Not all primary care physicians are comfortable with that. Often patients are sent to a neurologist who manages the medications. I have some patients who knew that this was coming to Tallahassee and I am managing their medications, but usually it is either a primary care physician or a neurologist as the first step. Yes.
Have you had patients that have taken both medications, but yet the DBS work?
So the question was whether I've had patients taking both medications and yet DBS has worked. And the answer is absolutely yes. DBS for essential tremor will often work better than the best combination of medications for a particular person. That's not usually the case in Parkinson's disease, but in essential tremor, you're often able to obtain better tremor control than the very best you're able to get with the medications.
I have a question from our online audience. How long does it take to get the surgery?
So the question from the audience was, how long does it take to get the surgery? The process from initial evaluation, initial meeting with me, to actually placing the electrode is usually on the order of, depending on scheduling, 6 weeks, something like that. The surgery itself, the placing of the lead into the thalamus, that takes about an hour and a half. And then the battery placement takes about 20 minutes.
And I have a follow-up question to that. How do they schedule an evaluation to get surgery?
So the question was, how didn't patients schedule an evaluation to get surgery? We can have the office contact information that's put up in the Zoom link. You don't need a referral from a primary care physician or anything like that. You can simply contact the office and get set up for an appointment. Stretching or a question?
Okay, I know someone who thinks that they're under stress. Is that any indication that they could be more susceptible to eventually develop essential tremor?
Yeah, so the question was, an individual who has very dramatic shaking when under stress, and is that a sign of proceeding on to developing essential tremor? The answer is maybe. Certainly essential tremor is made worse with things like caffeine, sleep deprivation, and significant stress. So if you already have some mild tremor, but it's not particularly troublesome, but it gets a lot worse when you hadn't slept and have to give a big talk, then that is essential tremor. It's just essential tremor that only becomes problematic in a particular situation. But a lot of people, especially people who have to do a lot of, or who are nervous about public speaking or heights or something, can get such a massive adrenaline surge that it could cause tremor in that situation, but doesn't mean that they have essential tremor. So the question was, is hypnosis a treatment option for essential tremor? No. There's really zero data to support that. There are instances where people, as I said, their tremor is exacerbated by other things going on with them. If they have a lot of anxiety, for example, and treating the anxiety, I don't know anything about hypnosis for anxiety, but treating the anxiety by whatever means could reduce the tremor to a point that it was no longer troublesome. So in that sense, they can be related.
I have an online audience question. They asked, after surgery for DBS, are there any limits on exercise or hiking, swimming, things like that?
Right. So the question from the online folks was, after the electrode is placed, are there anything that they're not allowed to do, such as hiking or swimming or anything like that? The answer is no, absolutely not. No issues with flying, no issues with swimming. The only thing that I do discuss with folks before surgery is if people do a lot of hunting, especially with rifles and shotguns. The only thing that changes is the battery goes on the other side instead of being on the side where it would be hit by the gun. So no restrictions. Yes.
Do you ask people if there's a side they would prefer, or do you have a side?
So the question was whether people are asked which side the battery goes on, or whether I have a preference. Virtually always people, I ask folks, which side do you want it placed on? I really have no preference. If someone already has a pacemaker, typically I'll put it on the other side just to reduce confusion over which device is getting swapped out. But other than that, or for example, if someone had a history of cancer and had a port, it might go on the other side. But outside of those rare cases, no, it's whichever side is more comfortable for people. I've had one patient who said that they were a side sleeper and always curled up on one side and they wanted it on the other, and I said, fine.
I have an online question. Would DBS help individuals with Tourette's?
So the question was whether DBS helps people with Tourette's. And Tourette's syndrome is involuntary, often either abnormal movements or speech. Usually it's, if you think of someone who has a tic, that abnormal, can't help themselves every few seconds, they have to do a movement. There's a lot of research into that. DBS actually has been used in patients with Tourette's with success. The problem you run into with Tourette's, with depression, used to be with epilepsy, their DBS does work for a number of different things. The targets are different, but DBS does work. The problem you run into is insurance approval. And currently, DBS is approved for essential tremor, for Parkinson's disease, for dystonia, and epilepsy. And if you don't have one of those conditions, you have to basically look for clinical trials or be able to afford the procedure on your own, which is hard. You had a question?
So after the DBS, it eliminates the need for any medications that you prior had been taking?
So the question was, after DBS, does that eliminate the need for medications? In essential tremor, that is often the case. That's basically never the case for Parkinson's, but for essential tremor, once patients have reached their optimal programming, it is very common, and in fact, it's extremely common that patients are able to at least come down on medications or to come off entirely, or if they're on 2 medications, to at least come off of one entirely. In essential tremor, that is the case. Another question from the back.
Well, it just jogged my memory thinking about Tourette's. There are other things that DBS is currently a lot of comments.
Absolutely. So the question was about other things that DBS is currently being studied for. It is being studied for obsessive compulsive disorder with some excellent results, being studied for depression with some very encouraging results. There are a number of other conditions for which DBS is likely to be used as standard of care in the future, but hasn't simply reached that point yet. Follow-up question.
Dyskinesia with psychotropic drugs in reference to the involuntary motions. Is this being seen that it could be used for mental health patients?
So the question was about the use of DBS for dyskinesias in patients who are on various psychoactive medications. In general, that's not the first line. There are studies on DBS for tardive dyskinesias. In the vast majority of cases, though, medication adjustments are the first line. Correct. Not only tremor medications, but changing the psychoactive medications, altering those, which doesn't always work, but that's absolutely the first line. You're sort of competing against yourself a little bit, and it is definitely challenging. We have other questions from the online audience.
Yes, so with tremor that is exacerbated by anxiety, are there certain medications for like anti-anxiety medications that could help with that?
Yeah, so the question was about patients who have a tremor as a result of anxiety, and are there medications for that? There absolutely are. They're not the primidone and propranolol medications. These are specifically psychoactive medications to address the anxiety. And that usually, instead of going through a neurologist, usually goes through a psychiatrist, though certainly neurologists are also doing some of the same work.
How large is the incision on your head?
So the incision, so the question was, how large is the incision on the head? And that big. So a very small orange, a C-shaped cut, the size of maybe a plum. All right. And it's behind the hairline, which means that you'll never see it. Well, yes. We discussed the haircut part of things in the office setting. Yes, sir.
For those of us not troubled with hair,
So the question was for those who are follicularly challenged, is the outline of the lead visible under the scalp? In patients who are really, really thin or have thin scalp, I will on occasion take a couple of extra steps to make sure that everything is flush, all right, so that there's not a bump. Typically, we're talking about a couple of millimeters anyway, teeny tiny, but still there are steps to make sure that there's a smooth outline. And then the wire itself absolutely is not visible under the skin. That's right. Other questions? All right. Well, we've covered a lot. Lisa Smith, our DBS coordinator, is here in the back. We also have the information from Boston and the lead and battery. If they're not making the rounds, we'll make sure that people have had a chance to do that. But I just want to say it's been enormously fun coming to Tallahassee and bringing this to Tallahassee. This was not available before I started here. We've been doing this for a couple of years here now, and it's been an enormous privilege and a lot of fun because this is not something that's been available in the area. It's not something people really knew as an option, and so we're really bringing a lot of good. One last question.
yeah, for veterans with PTSD, is this a problem with that?
So the question was about PTSD and if that's a problem with DBS. No, it's not. If there are particular triggers that may change how we approach the OR day for the testing. All right. And then I've absolutely had patients with PTSD that they need medicine to get an MRI. They can't be in the MRI machine and things like that. So there are absolutely changes that we can make, but the presence of DBS will not affect PTSD. It's not going to make anything worse. All right. Well, thank you all. Thanks to the folks on Zoom.
wage to $15 an hour means they can no longer afford the automatic salary increase. The district and teachers union engaged in intense back and forth over the issue since January of last year. As the war in Ukraine wages on, communities around the globe are coming together to try and help those being impacted by the fighting. Right now, a donation drive is underway at a Valdosta church to try and help those in Ukraine who've been cut off from supplies. Monday, buckets on top of buckets inside the Central Avenue Church of Christ as people in the community donating tons of supplies to fill up each bucket for refugees. The goal is to fill 1,000 buckets. These buckets including hygiene products, kitchenwares, batteries, and flashlights. Once filled with supply, they'll be transported to Nashville through a collaboration with Healing Hands International. From there, they'll be shipped to Ukraine or refugees in Poland. If you'd like to help, call the Central Avenue Church of Christ at 229-242-6115. Again, that's 229-242-6115. Well, before your next vacation, you will need to find out whether you can leave your mask at home. Officials are no longer enforcing the federal transportation mask mandate, but your local government or transit organization might have its own rules. And if wearing a mask is up to you, health experts have some advice to help you make that decision. Amy Kiley has more.
Masking up while traveling is now optional most of the time.
Excited. If you want to wear them, If not, then don't.
A federal judge in Florida has struck down the Biden administration's public transportation mask mandate. While the ruling is reviewed, the TSA and a growing list of U.S. airlines and other transit organizations say they won't enforce the rule.
It looks like it's a done deal. I mean, the administration, rather than saying they were going to appeal right away and try to get a stay, they basically acquiesced in the decision.
Amtrak says masks are now optional, but stop that train. Local governments and travel organizations can still enforce their own regulations. These transit systems are some of the first to say they will continue requiring masks. These say they will not. Regardless, the CDC still recommends choosing to wear a mask on public transportation.
Just because you're not required by the government to wear a mask, that doesn't mean you shouldn't wear a mask.
Experts recommend an N95 or similar grade of mask for the best protection.
Wear a mask during the times that are the highest risk. That is boarding the plane and deplaning, because that's when the ventilation system is not turned on.
I'll always wear my mask. I lost my grandmother to COVID a year ago, and so I'm very particular about the masks.
I'm Amy Kiley reporting.
The COVID cases for children are up for the first time in about 3 months. The American Academy of Pediatrics says more than 33,000 kids tested positive for the week ending April 14th. Officials say that is drastically down from the peak in January, but it's the first reported in 12 weeks. Johns Hopkins University says new cases for all age groups are up in more than half of the United States, but the daily rate is down compared to 2 months ago. All right, the time now is about 12:08, and this is an absolutely beautiful view from the Weatherspoon camera over Doak Campbell Stadium. Yes, a lot of blue. It looks really nice out there. Just make you want to go outside.
Hello, we are not available now. Please leave your name and phone number after the beep. We will return your call.
This is Armin. OMB declining for the happy hour with Darko on April 22nd. Thank you so much for the kind invitation. Have a good time. Bye-bye.
63 right now, Tallahassee Airport, that's all. We're at 59 in Thomasville and Valdosta, we're at 64, all kinds of sunshine out there. Those top temperatures, they're going to struggle to climb into those middle 70s. That's where I think their warm spots are going to get. Not everybody's going to get that one, especially not if that breeze keeps doing what it's been doing throughout the morning, pumping in that cool, dry air. And then tonight, when those get a little bit warmer tomorrow afternoon. I think we get back closer to 80 degrees. And there's really nothing but good stuff in this forecast, unless, of course, you're looking for more rain. But I think a lot of our area could use a couple of days to dry out and get some sunshine to make it look a little bit nicer out there. Not much going on satellite radar composite style, but way up over parts of New England, they are still getting snow. Some areas measuring that snowfall in feet. That's crazy for this time of the year. Not a lot of clouds around here. There isn't going to be. It's going to be a beautiful day to get the top down if you can, to spend some time outdoors. Right now, things all warming up. We'll talk about a continuation of that warm up later this week. When I get to that full forecast in just a few.
Jeez, that does sound crazy that some people are dealing with feet of snow. Yeah. Glad we don't have to worry about that. All right, we'll see it in just a bit. Well, let's go ahead and take a look now at what is trending today.
In clicks today, first, Wawa is planning to bring stores to Tallahassee and throughout the Panhandle by 2024. This comes as the 10-year anniversary of the opening of the first Wawa in Florida in years. That location is in Orlando, across from SeaWorld. The popular East Coast convenience store chain employs 10,000 Floridians currently and hopes to open its 250th store in the Sunshine State this year. Next, a Florida man has set a Guinness World Record for watching the same movie at the theater nearly 300 times. Ramiro Alanis watched Spider-Man No Way Home 292 times, logging 720 hours of total viewing time. To break the record, he was not allowed to nap, use his phone,